Electronic Health Records at Montana State Hospital, a policy analysis by Mark Hender. Electronic health records, an absolutely necessary feature of psychiatric treatment. The significant value of electronic health records, EHR, cannot be understated. From a reduction of healthcare costs to more efficacious treatment of mental illness, to a greater availability of already stretched resources. Policy analysis was the means through which this change was explored. Whether these changes will be instituted remains the prerogative of administrative officers at Montana State Hospital, MSH. While considering the effect of a policy analysis on the application of an EHR on the inpatient population at MSH, the ability to apply such remains in the hands of administration. We can address the understanding of providers and administration surrounding EHR use through policy analysis. We can increase the quality of care they offer. Montana State Hospital, a psychiatric facility reliant on paper documentation while research supports the use of an EHR. The goal of the Practice Improvement Project has been to examine the documentation policy at this facility and determine the necessary steps to take to update the policy so the hospital aligns with the evidence-based practice of EHR utilization, thereby improving the health of patients. Documentation within healthcare systems has metamorphosed in the last several decades, driven by evidence-based care and policies. How have facilities varied in policies and regulations regarding the transition from the use of handwritten charting to the utilization of EHR? This problem was addressed by analyzing MSH documentation practices, comparing research on handwritten and EHR, and then presenting an informal recommendation to hospital management and administration. It is the hope that an update in said policy would ultimately benefit the community and improve quality of care. Mental health resources are limited. They are actively being stretched thin. The need for them is increasing, and resources are not being expanded. Healthcare professionals are charged with the responsible allocation of such assets to the treatments and evidence-based practices proven by research to be considered most efficacious. A change from paper documentation to EHR at MSH has been proposed as a means of more efficacious use of limited resources and an improvement in care for their inpatient population. This was accomplished through policy analysis, examining current policy, and using research to encourage MSH to update such to reflect a change to an EHR. This policy analysis concerning policy MS-03 is intended to encourage the transition from handwritten records to an EHR system. The significance of EHRs for nursing practice is marked. For those advanced practice nurses involved in inpatient psychiatry, the lack of an adequate EHR is a primary concern. The facility with an effective EHR will have more up-to-date information on each patient, their current condition, behavioral status, additional features of treatment, meds, clinical notes. The patients well monitored by and the providers guided by EHR will find themselves more engaged in care, focused on treatments, mindful of goals, and more compliant with medications and treatments. Some studies show that for each sequential psychiatric break, mental illness becomes more treatment resistant. Because EHRs ensure higher quality care, medication compliance is more likely, presenting as an approach that literally reduces the severity of mental illness. In the future, psychoses could become less severe and easier to treat as patients experiencing psychotic breaks receive treatment efficiently through EHRs. Research suggests that some patients may recover from their first episode of psychosis and never have another. Support for this project from MSH is community member and managing nurse Tamara Tharp. Also from MSH is Carter Anderson, CEO. And from Maryville University is Dr. Tanya Crystal. For generations, we have relied upon fallible paper being rubbed upon by rocks and tars. However, EHRs will allow the more effective treatment of the mentally ill, allowing them to remain in their communities, ensuring they are treated and able to participate in society. When we look back on the history of psychiatric treatment, it will seem criminal that we did not quickly adopt EHR use as a means of improving care quality. The compassionate choice is to drastically expand EHR use so as to ensure that those suffering with mental illness have their clinical data stored effectively. Patients effectively cared for return home quickly and are able to remain at their jobs, in their homes, and with their families. And what more therapeutic treatment is there than to simply get to live one's life? In our technological era, healthcare generates enormous amounts of clinical data. This data is stored digitally in the form of an EHR as a central repository of healthcare facilities. The practice setting for this project relies on paper documentation despite research supporting use of an EHR. How have facilities varied in policies and regulations regarding the transition from the use of handwritten charting to the utilization of EHR? What is the impact of using EHR for documentation compared to not using EHR on the quality of care? Databases consulted were PubMed, Core.uk, EBSCOhost, Cochrane, Maryville Online, and Google Scholar. Recurrent concepts for EHR: improves care quality, reduces errors, establishes care continuity, and provides opportunity. From the articles arose 4 themes: improvement of care quality, reduction of errors, establishment of care continuity, and providing opportunity. These promote and substantiate the objective of the scholarly project, particularly the need for the updating of policy to reflect EHR implementation. Direct care nursing staff have observed EHR as useful, allowing quick access to medical information. EHR also has the direct result of reducing medical and clerical errors, improving care efficiency. Providers support the notion of improved care continuity with EHR as it allows patient information to be easily transferred among healthcare professionals. EHR also provides the opportunity to advance care practices by recognizing contraindications before the provider does. Studies have shown that the use of an EHR directly improves quality of care, allows quick access to information, improves effectiveness of providers, and leads to an increase in available funding. EHR also increases efficiency of record keeping, expands access and validity. The majority of providers support the notion of EHR doing so, and it also provides the ability to proof records and orders. Patients reported that providers who use EHR have higher care ratings related to criteria on understanding and follow-up, exhibiting the feelings of patients regarding provider use of EHR, and that there is the belief EHR improves care quality. EHR use relies on a nursing populace that is comfortable with computer use to benefit patients and the healthcare system. Improvement in care quality comes as a direct result of relying on computer-based systems to ensure evidence-based practice. Reduction of errors. EHR reduces medical errors by ensuring wider access, verifying medical orders, supporting input of legible orders. Providers agree that EHRs aid in the reduction of healthcare-related errors and improved communication among clinicians. EHR prevents errors by alerting providers to potential contraindications, thereby reducing the prescribing of drug-to-drug interactions. This displays the ability of an EHR to prevent medical errors from occurring, which directly results in improved care quality. Establishment of care continuity. Patients believe providers using an EHR offer greater care, offer better education, get patients results, offer enhanced care coordination, have better healthcare outcomes, make better clinical decisions, and present evidence of patient belief that wider availability of medical records leads to greater care. Opportunity to investigate patterns and future advancements exists through EHRs. Test results are more widely available for study. Treatment patterns are easier to quantify. Identified can be areas of spending, reducing debt, as well as opportunities for drug repurposing. The review of available literature on EHR shows substantial support for its adoption, significant cost savings, improved outcomes, improved patient engagement, enhanced data security and e-prescribing, data exchange, greater accessibility, improved medication management, and improved information access for the patient. The father of social psychology, Lewin, developed his change theory in 3 stages: unfreezing, change, refreeze. The unfreezing would be the letting go of old habits and patterns, such as handwritten charting. The second step being change would be the adoption of an EHR by translating patient information from paper to EHR and employee training with necessary computer equipment. Refreezing would be continuing education regarding EHR use, as well as updating computer equipment as needed to keep up with EHR needs. The Health Information Technology for Economic and Clinical Health Act, or HITECH Act, is part of the American Recovery and Reinvestment Act, or ARA, of 2009 and creates incentives related to healthcare information technology, including those for the use and implementation of EHR systems. Federal investment in EHR implementation has already reached $25 billion. The Centers for Medicare and Medicaid Services have developed a program that encourages healthcare facilities to upgrade their methods of documentation to an EHR. To procure funding, facilities must work to implement an EHR that meets criteria set forth by the Centers for Medicare and Medicaid Services, particularly their interoperability objectives. For the data collection portion of this study, data was collected regarding EHR policy at MSH, established EHR systems and policies, as well as the means of establishing an EHR. To gather information on how MSH currently regards EHR in their policies, access to MSH policies was requested and obtained. Following the receipt of permission, a search was undertaken to review each policy and determine what implications it may have on the implementation of an EHR system. The search produced several relevant policies, which governed or dictated how patient records were to be used in both analog and electronic formats. These policies were then reviewed in conjunction with a wide variety of other materials regarding EHR implementation. The Centers for Medicare and Medicaid Services interoperability objectives offer criteria for the reception of funding for EHR. Again, in 2009, the founding of new regulations intended to promote the development of a national healthcare infrastructure were founded. Part of the legislation known as HITECH establishes financial incentives for the adoption of an EHR. A quantitative survey was used to determine MSH stakeholder conceptions of EHR adoption. The data survey was as follows. Will the CMS IOO be effective? Will MSH be able to facilitate such a budget? How likely would the facility be to adopt CMS IOO? Is CMS IOO supportive of improving patient care? Does MSH currently have non-budgetary resources available to support implementation? And what degree of coercion is necessary for implementation? As represented in the conflict among responses, policy analysis is representative of politics in general in life. Although EHR benefit is overarching and the evidence substantial, some, when surveyed, still have their disagreements. EHRs have been shown to improve quality of care, provide for safer and more reliable workflows, reduce errors, improve patient experience, engagement, and management, increase access to complete and accurate information, lower operational costs, improve security and data, reduce duplication of testing, enabling the streamlining of healthcare information amongst facilities, the reduction of delays in treatment, the promotion of legible and accurate documentation, and the enabling of safer, more reliable prescribing. According to the results, the majority believe the CMS IOO would be effective at MSH. One member expressing considerable doubt leaves the likelihood of there being some realistic concerns regarding EHR adoption. This likely means that although EHR implementation is widely shown through research to be beneficial, that stakeholders understand there to be significant obstacles. The board did believe that there was a high likelihood that MSH would in the future adopt CMS IOO. This is likely because stakeholders understand the value of an EHR in improving patient care. The board did agree that MSH retained the funding necessary for implementation, while also concurring that there would be an above-average need for coercion of such. Analysis of EHR implementation has roots in understanding the application of technology in healthcare. The core strength of this policy analysis was its realistic approach. For the benefits of EHR implementation at MSH, to the barriers that might present difficulty in its establishment, this study promoted to stakeholders efficacious means on how to go about the conceptualization of EHR. The cost of EHR execution being the most significant variable was directly addressed, and although the cost was prodigious, it was not insurmountable. In summary, the findings of this policy analysis on the conceptualization of EHR at MSH are encouraging. Among those executives surveyed, the results show that there is the belief that EHR will not only be possible, but that it will overall be beneficial to the facility and its patients. The scores for survey questions of this policy analysis are not all optimistic. In fact, they are more realistic and indicate the sense that those surveyed believe establishing an EHR will be possible, but that there will be challenges. The results show that MSH stakeholders have an understanding that though EHR will prove beneficial once established, there are a plethora of challenges that must first be undertaken at the facility in order for it to be fully adopted.